and community-based organizations is 58%. And then we have some pharmacy wellness hub data from our pharmacists from 2024 to 2025. What you can see here is that 77.46% self-referred. And I feel like that is way more than any of the other categories that we have here. Our healthcare provider is for 14.8, and then we have a 0 for CBO and MCO, and 8.445 is a no. And also for last year for our diabetes prevention program, it was 100% self-referred. Does anyone have any questions about the information that I just presented before I move on? No? Okay. Um, so we are going to go over our learning objectives for today's session. So we really want to understand the role of building strong referral networks in connecting residents to DSMES programs, recognize how EHR records can be leveraged to streamline referrals and track resident engagement. We also want to identify strategies to strengthen collaboration between providers and community organizations to improve referral pathways. I feel like this one is especially important because we see that a lot of DC residents or people that are into these programs are self-referring, and I feel like we could probably see an increase if we just kind of use our resources around us. Lastly, I want to apply practical approaches to increase resident participation in DSMES services. So today I'm very excited for our speaker. We have Laura Edwards. She's the executive director of Collaborative Health Solutions, which is a nonprofit health organization. She has been a nurse for 40 years and she has worked in public health for 30 years. And she started the first DSMES umbrella program in 2007 while working for the NC Division of Public Health. And she also wrote the original version of the DSMES toolkit for the CDC in 2018. She enjoys her work at the state, local, and national level, and her expertise and passion in serving underserved rural communities.
All right. You ready for me then?
Yes.
All right. Thank you. Hi, everybody. I'm so excited to be here. Thank you for inviting me and letting me share some of my experiences with you. And I look forward to learning from you all as well. So today, as Tyler was mentioning, we're going to talk about strategies to strengthen referral networks for DSMES, or diabetes self-management, education, and support. We'll talk about how to collaborate effectively with primary care providers, healthcare systems, community organizations. And as you know, we're doing all of this because we're trying to improve patient self-management and improve their outcomes and quality of life. So we'll go to, let's see, we can go next slide. Okay, so let's just to level set just for a minute. I'm sure that you are all aware of what DSMES is, but it's evidence-based service designed to support diabetes self-management so that, as I said, patients can better self-manage their diabetes, have better outcomes, better quality of life. It is provided by trained healthcare professionals. Is formal DSMES, especially recognized or accredited programs, have a structure of trained clinical folks, while we can also use community health workers and other folks who might be outside of the usual care team that you think of for DSMES, but everybody can have a role in DSMES delivery. So we focus on education and skill building and ongoing support. So if you're not familiar with the DSMES toolkit, I am not plugging this only because I wrote the original version of it. I don't think anything that I wrote on there exists anymore. That was way back in 2015. But it is a fantastic resource. It can be kind of a one-stop shop for you if you have questions about DSMES, if your organization or any organizations that you're working with might be interested in pursuing accreditation or recognition for DSMES so that you can bill and get reimbursed for providing those services. You can use your favorite browser and do a search for DSMES toolkit, or There's a link here and a QR code. That is the very first QR code I have ever generated. So if it doesn't work, I'm just going to be crushed. But hopefully it works and takes you to the toolkit. If not, Google will get you there. So next slide. Thank you. So why do referral networks matter? So when I was looking at some of the data that Tyler shared ahead that she's already gone over with you guys, and I was looking at the percent that are self-referred for your programs, and that's just incredible. It's not what I normally see. And I know folks who are coming for DPP or diabetes prevention programs can self-refer, but folks who are coming for a formal DSMES to a formal DSMES, that to me means a recognized or accredited DSMES service, have to have a provider referral. And that can be, a physician, a DO, an advanced practice nurse. I think RDs might be able to refer. Pharmacists cannot, which I think is silly and hope will get changed. But the point of doing that, and while I overall, this is my personal opinion, disagree with anybody having to have a referral for an education program, because why do we want to put that barrier in place? But the reason that it's been there, and it's been there since DSMES started over 20 years ago, is to create that relationship between the provider and the primary care provider, or the patient's provider, and the DSMES provider, so that we can have information flowing back and forth. You have to have a referral from a provider if you want to bill. Now, if you're serving a whole lot of uninsured patients, you might not mind having folks who are self-referred. But if you do have folks who are self-referred, but they have insurance, and you are an accredited or recognized DSMES program, when people self-refer, try to reach out to their primary care provider and get a referral so that you can bill. It's important for the sustainability of your program, and it'll help improve your referral relationships, because once the provider is able to see what great work you do and the good outcomes that the patients are having, they may send more people your way. So that's kind of an aside based on the data that I saw. But strong referral networks just mean that patients can then access DSMES services when they need them. It helps providers coordinate care, and overall we're improving outcomes. It'll reduce cost over time by preventing complications, which is the whole point of DSMES. But since a healthcare provider has to refer the patient to DSMES, as I said, then the DSMES services success or failure really can hinge on how good your referral networks are with their providers and the referral processes. The providers need to know about your services in order for them to refer patients to you. So that might mean starting some marketing outreach, or expanding what you're currently doing. So we'll talk about in a minute just some of the key partners that you might consider. I just want to say again, I'm so impressed though that you at the percent of self-referrals that you have. So some of your marketing efforts must be working great, because you are getting people into your program. I'm not sure how you're doing that, but whatever you're doing is working. So continue that, but also consider how to reach out to expand your referral networks to drive more referrals to your programs. Okay, we'll go to the next slide. Thank you. So who are some of the key partners that you could consider doing outreach or marketing efforts to? So obviously primary care providers, this would be whoever your patients see on a regular basis. It could be a nurse practitioner, it could be a PA, it might be a doc or a DO. Doesn't matter who it is, but it's really the individual that the patient has their primary care relationship with. We could also consider endocrinologists and specialists. I don't know about in DC, but I can tell you in North Carolina, we don't have enough endocrinologists to go around, and they're really hard to reach, particularly in rural areas of our state. So being sure that they're aware that there are referral programs can help actually ease the endocrinologist burden for education. So hospitals and other clinics, pharmacies are a fantastic resource. Pharmacists are trusted healthcare professionals, and their recommendations can often make a huge difference. Lots of times they spend more time with the patient than the provider does. So consider, and I think you guys are working in pharmacies anyway, and some of you may be pharmacies, but if not, consider reaching out to pharmacies. I'm a big fan of community-based pharmacies myself, but the corporate ones you may also be able to establish relationships with. Then look at community-based organizations. What's available in your community? Where are your patients going anyway, right? Are they going to the Y? Are there senior centers, community centers, places where families gather, where you might be able to recruit folks for your programs, and also talk to these folks about having them refer patients to you. Payers and insurers are another one. I don't know how much you all interact directly with payers and insurers, but if you have relationships with them, you can certainly reach out. Most of them have a list of who their patients with diabetes are, particularly their patients with diabetes whose A1C may be high, and they might really benefit from some education, and they may be willing to send information to the patient to encourage them to seek a referral from their primary care provider for education. So just some things to consider there. Okay, we'll go on to the next slide. So what are some things that you can do to build relationships with primary care providers or PCPs? My experience I've been working in DSMES since 2006. So in the last 20 years, I will tell you the number one thing that I have learned is that most providers have never even heard of DSMES. They don't know what it is. They don't know who offers it. They don't know the benefits of it. They really don't know anything about it. So educating primary care providers on the benefits of DSMES can be hugely advantageous. There are studies that show that a patient who completes DSMES can decrease their A1C by as much as some medications. And that's for education because it encourages some of the lifestyle change, helps the patient self-manage, but that's pretty impressive outcomes. You can look, the DSMES toolkit has some resources about the benefits of DSMES, and then the DSMES promotion playbook, which is also part of the toolkit. I've put a link here. This has got some fantastic marketing information in there that will help you educate not just primary care providers, but others on the benefits of DSMES and what the referral criteria are, why it's important for you all who have recognized or accredited programs that you get the referral from the provider. That way you can bill and you establish that relationship with the provider. Sharing success stories and patient outcomes are incredibly powerful. So if you have a patient who has come in and they're a patient of Dr. Jones, and you share this person's incredible outcomes with Dr. Jones is more likely to refer other people to your program, right? So some of this is, it's just kind of basic marketing that makes sense. You know your communities. You probably know the providers, you know the community resources. So how can you work those relationships to help, one, reach more patients, and two, get more folks into your programs so that you can remain sustainable. I highly encourage you to make the referral process as simple and as efficient as you can. It depends on your structure and where you're based. Some folks, if you're offering DSMES at your own location, then doing an internal referral from your own providers is super easy. I have seen organizations do standing orders for their primary care providers. So if a patient has an A1C greater than 9, they automatically get a referral to DSMES. I have seen folks use EHR systems where patients have to opt out instead of opt in. So everybody gets referred unless they say that they don't want to. So there's some just simple tips and tricks that you can use depending on what the setup. And I know one DSMES program is one DSMES program. You all may have completely different partners, locations, populations, but you know what's going to work with your folks. The primary care provider is generally the first point of contact for patients, so educating them about DSMES and making the referral process simple is critical. As I've mentioned already, you're going to build trust through that communication and sharing your patient's success stories. One of the things that I would suggest when you're first talking with providers, or if you're trying to increase your referrals, is talking to them about the 4 critical times to refer a patient for DSMES. These are type 2 folks to DSMES. The first time is at diagnosis. That can be a hugely overwhelming time for folks to receive that diagnosis. Their brain often goes to worst case scenarios of amputations and vision loss and all of the complications that that we want to help them prevent. And DSMES can be a really good mechanism for them, not only to manage their own disease better, but it can be kind of a support network for folks as they're interacting with others who are experiencing some of the same things that they are. So at diagnosis is kind of the number one first choice for when to refer annually, or if a patient's not meeting treatment strategy. So if they're on medications and their A1C is still high, yes, you want to look at and see if change in meds is necessary, but also how are they doing with their other lifestyle interventions, and are working in community organizations like y'all. Are they getting education that is culturally appropriate, linguistically appropriate, talking about the foods that they like to eat, or access to the healthiest food options they have? If they're having to do their shopping at Dollar General, how can we help them make better choices, right? So it's tailoring it to meet the patient where they are, and also designing your program so that it supports folks in that way. If complicating factors develop, is another good time to refer. And then when a transition in life or care happens, some major shift in the patient's life, and they might be able to use some more support. So those are the 4 times that I think are really important to have a provider refer. There's no wrong time. I'll say that. Anytime you can get patient into education, it's a good thing. But those are the times I think that I would really prioritize. So as I said earlier, most providers don't know what DSMES is. So educating the referral providers on the benefits is super important. Their patients are going to work with the DSMES team to set their own goals. And this goes back to what I said about meeting patients where they are. They're going to track their goals. Y'all will track their goals as a program if you're offering DSMES. Learn how to manage their diabetes using knowledge and skills and tools. It helps build their confidence and their emotional strength. They can practice how to fit their diabetes care into all of their daily routines, because that diabetes can impact so much of what they do. They have a very small amount of time with the provider, whether that be a pharmacist or a nurse or their MD, DO, whoever. So they get so little one-on-one time that the more information that we can give for them to manage their diabetes while they're not in a clinical setting, the better off they're going to be. Excuse me. And then we want to help them find ways to get support. They may get support from folks who they're in a DSMES program with. It could be family, it could be friends, it could be other community resources. There may be diabetes support programs that you all are running or that you know of in your community that can be a great place to connect folks to as well. So providing the information to the potential referring providers is super helpful. All the information needs to be culturally and linguistically appropriate, as I've mentioned, for patients and for the providers that you're trying to reach. If they're serving a Spanish-speaking population, then be sure that they have information that's in Spanish. It's culturally appropriate as well. When we're targeting patients in terms of marketing or education, use plain language, flyers or brochures that have pictures of folks who look like your community on them, so that people can see themselves going to these classes, because it's depicting people that look like them and that they may feel more comfortable with. You can email providers templates and talking points that they can use to educate patients with. And then any health literacy resources that you all have, visual aids, graphs and charts, pictures, plain language glossaries, anything like that you can use that will capture someone's attention and make them feel more comfortable about attending DSMES, or if it's a provider, that'll make them feel more comfortable to refer to DSMES. So again, the DSMES promotion playbook is a fantastic resource. There are templates in there. I think you can put your own logos and things on. So, it does a lot of the work for you. Any questions about that so far? And I did want to say, and I didn't say this in the beginning, and I should have, I would love for this to be interactive. So please feel free to put any questions or thoughts or anything in the chat, and you are welcome to stop me as we go. I think we'll have time at the end for some conversations as well.
Laura,
Yeah.
could you review or mention the 4 critical times to refer? For some reason, I may have
Yeah.
missed a couple. I
Yeah.
know you mentioned diagnosis,
Yeah. The first one is at diagnosis.
right?
The second one is annually, or if
Okay,
they're not meeting a treatment target. Third one is when complicating factors develop.
gotcha,
And the fourth one is if there's a transition in life or in care.
gotcha. Thank you.
Yeah, of course. Okay, we will move on to the next slide then. I don't see any questions in the chat, but y'all let me know if I miss anything. So I've talked about this a little bit already, but engaging community organizations can be a huge benefit. You all are working in your communities, you know the community organizations, you may be a community organization, but we all have partners that we work with on a regular basis. So I think it's a critical strategy to increasing access and referrals to participation in DSMES. Doing all of that will improve patient outcomes, especially in underserved populations. And I've already told you that that's the population that I'm most passionate about serving. I've been working with FQHCs in North Carolina at the local, state, and national level for 30 years. And I love that model. And you know, I walked into that. I don't know why they hired me at the FQHC, but they did. And I walked in and went, oh, this is what I'm meant to do. So anyway, huge believer in that. And that's the population. So my lens is always reaching underserved and particularly rural populations, but underserved populations. Because if we can reach that population, then we can reach just about anybody. Anyway, sorry, I'll get off my soapbox there. So anyway, community partners and community organizations can expand access by bringing DSMES into trusted, familiar settings. So this was a few minutes ago where I was talking about meeting patients where they are and where they're going anyway. So it might be the Y, it might be a senior center, it might be some other community organization. So you can expand access that way and leverage local expertise. There may be CHWs in some community organizations who would be willing to teach nutrition classes or cooking classes or something that's going to be culturally appropriate for the populations that they're trying to serve. So I've talked about some examples. It might be the Y. Faith-based organizations, great to partner with if you're not doing so already. Barbershops and beauty salons can be great partners. Local food banks and pantries, I'm sure y'all are working with them already. In North Carolina, we had a partnership with one of the larger food banks where if a patient came in who had diabetes, they would get a diabetes box. So it was foods that were maybe more appropriate for somebody who is trying to manage diabetes. So there's all kinds of community organizations out there who have resources that can benefit your patients. Schools and libraries and senior centers, again, these are places where people might be going anyway. Could you hold a DSMES class there? You know, any of those locations feel comfortable. And some of the populations that we serve may not feel really comfortable in some locations right now. And we want to go where they are anyway so that they feel safe and are open to these conversations.
Laura?
Yep. Yep, go ahead.
I was going to read the question in the chat. Do you have any recommendations for programs to navigate the individual versus group requirements for delivering DSMES services, especially for clinics that accept all types of insurance, including Medicare?
Yes. Thanks for bringing that up. That's a good question. So unless the rules have changed, and I'm not a billing expert, but FQHCs used to not be able to do group DSMES, and everything would have to be individual. You can do individual DSMES for any, okay, thank you for saying that's still right. You can do individual DSMES as long as you document that the patient has a learning need that requires it. if you'll look on the DSMES toolkit or look at the either ADA or ADCES standards for DSMES recognition or accreditation, it will tell you in there what some of those are. Some of it is if the patient has a language barrier, if the patient has a physical, not even disability, but a physical condition that precludes them from attending group classes. So there are ways around it. The provider would have to write some kind of an order describing that, but as long as you have that documentation, you can bill individually instead of group for those patients. I hope that helps. So going back to community organizations can contribute to DSMES in a number of ways. They also could provide diabetes support programs. That's a topic for another day, but just keep that in mind. I talked about this a little bit already, but providing space for classes in locations that are easily accessible. So are they on the bus line? Are they walkable? Are they, for folks who don't have transportation, could it be at a school where they might be going or their kids might be going anyway? Libraries, faith-based organizations, we talked about that a little bit. We've talked about promoting DSMES and really leveraging your existing networks to promote programs through their members. So if folks don't know, that folks who are your normal community partners don't know that you're offering DSMES, let them know. So spread the word so that you can get more referrals, more patients into your program, and then we're helping more patients as well. So it's a win-win. I am a huge fan of community health workers. We have long used probatoras in some of the FQHC work that we've done. I have seen them make tremendous progress with patients nobody else was able to reach or influence. So I just think they're so critically important. So using CHWs or peer counselors, folks who have already established trust in the community, they have lived experience that reflects that community. All of that is great to bridge healthcare gaps and deliver that culturally relevant education. And CHWs are a great part of the care team. Okay, what tasks do you assign to CHWs who are part of your DSMES program? So that depends on, that's a good question, and it depends on the CHW and what their expertise is, but you can train CHWs to present on just about any part of the curriculum. So if you're a recognized or accredited DSMES service, you have to have an RN, an RD, or a pharmacist be part of that clinical delivery team, but you can add whatever other members you want to the care team, whatever role. Not everybody has to be a licensed healthcare professional. I love using CHWs to provide nutrition information. If you can go and do a tour of a grocery store, making healthier choices in a grocery store, reading labels, doing on-site cooking demonstrations, physical activity, talking about safe places to be physically active. Some of the communities are not safe and don't have great places for folks to do that. So what could they do at home in their own apartments or wherever they live? So I think the short answer is CHWs can do just about anything in DSMES. I would not have them teaching the more clinical things like medications and that kind of stuff, but just about anything else. Anything that's related to lifestyle, I think is perfectly appropriate for a CHW to present, as long as they've been adequately trained on that and it's part of the curriculum. But huge fans. And that, I just talked myself into my next point, which is integrating additional services like cooking classes, grocery store shopping, support groups, and physical activity programs are great ways to engage your community organizations. If you're offering DSMES at your location, maybe you can have somebody from the Y come in and talk to your group about, starting with some simple basic exercise or just walking for people who are currently not doing anything. So there's lots of options, but I think it's great to consider the resources that you have available to you and plug them in where it's appropriate. Some community-based organizations who might be providing diabetes support programs may already have the infrastructure that they would need to become a recognized or accredited DSMES service. It's easier now than it used to be, and that it does provide a mechanism of sustainability in that you can bill for patients who have insurance. When you work with a highly uninsured population like I do, that's not always necessarily a carrot for folks, but sometimes it is. And the DSMES toolkit is a great place to find. There's a crosswalk of not only the standards, but the requirements of ADA and ADCES, which are the two organizations that are deemed by CMS to grant recognition or accreditation for DSMES. Okay. That was a whole lot of words, so I'm going to stop just a second. Any other questions? Okay, great. Thank you. Keep them coming. So what are some of the tools you can use to strengthen your networks? EHR integration for referrals is a really important one. And I know that we have, I think, 47 FQHCs here in North Carolina, and they use 8 or 10 or 12 different EHRs. So not everybody's on the same EHR. EHRs won't talk to each other. That's a whole nother soapbox for me for another time. But if you have a DSMES service in your own organization, using your EHR to generate automatic referrals to DSMES for patients who have diabetes is a super simple way to go. If EHR integration is not where you are in your organization, and some organizations just are not, have a standardized referral form. I've seen people do things that look like prescription pads where the provider can just sign it and hand it off. I've seen standing orders been used. Like it doesn't necessarily have to be super sophisticated. It's whatever works in your organization or for whoever you're sending your patients to. Keep it simple, right? Super simple. Sharing care plans is a great idea. The more information you can share back and forth between your DSMES service and your provider, the more the provider is going to be able to see what the patient is doing, the progress they're making. It builds trust and relationships, and also may gain you some more referrals. I think I mentioned earlier on that I've seen EHRs that have an opt-out mechanism so that the patient has to say no. They don't want a referral to DSMES. Everybody gets opted in unless they specifically say no. And that's something that I've seen set up in EHRs. So the provider doesn't even have to check the box for the referral. It automatically happens unless the patient says they don't want it. So the provider does need to talk to the patient about it, but then there's no other step for the provider to do unless the patient says no. They have to actively decline. Integrating templates into EHR can help team members document patient goals. So if you can document their A1C changes, you can look at demographics, you can look at some of the information that you would pull for quality improvement reporting if you're a recognized or accredited program and you're having to do that. So the EHR is great if you can make it work for what you want to do. And sometimes either you can't or it would cost money to make changes to the EHR, and that's not always feasible in every organization. Totally get that. Virtual tools can also expand access to patients who have transportation or scheduling barriers. So you can do virtual DSMES, so you can offer things online. We obviously saw an uptick in that during the pandemic. And for some folks, that works really well, and they really enjoy it, and they get a lot out of those classes. Virtual classes are not for everybody. Some people do better with being in person and being amongst peers and feeling supported that way. So you kind of have to gauge what works with the resources that you have and against the needs of your patient. It's hard to offer DSMES at a time that works for everybody. You know, the folks, if they don't want to come 9 to 5, then is your organization going to commit to staying open late, you know, one night a week or one night a month to do a DSMES class or having somebody there on the weekend? Not every organization is, right? Because it's not just the team that's there to provide the education, but then do you have to have a front desk person who comes? Do you have to have security in place? So it's the whole spectrum of offering after hours. The easier way to get around that if you're doing after hours is to offer it in a community location that's already open during those hours. So just all of those things to consider and think about. Mobile applications. So there's an app for just about everything now. There are lots of apps available for folks to track medications, weight, physical activity, all of those things that can be a benefit and an adjunct to the education that you're supporting in your program. And then if you have an online patient portal, if you're a healthcare clinic or community organization that has a patient portal, excuse me, you can have patients use that to schedule their own appointments, that they can track their progress, see their lab work, and communicate with their healthcare team. So just some things to think about to strengthen your networks. Data dashboards to track referral outcomes, I think, are fantastic. This goes back to one of the first slides that Tyler showed from y'all's landscape assessment. How do you know where your referrals are coming from? Because if you have a provider who starts sending you a bunch of patients, you want to be sure that you're reaching out to them and saying, thank you so much, we appreciate it, here's what's happening, here's, good, whatever the good things are that you can use to reinforce that behavior. All right, so let's move on to the next slide. I'm almost done because I want to have some time for conversation if we can. So overcoming barriers, we've talked about some of this already, but some of the things that you all need to think about is the screening for health-related social needs, or what we used to call social determinants of health. You probably will hear me continue to call it that. And we need to screen to intervene. So if we are screening for social determinants needs, we need to be sure that we've got a resource to offer the patient that addresses that need, right? So we have to look at individual challenges that the patients may have, and that could be something as simple as they don't have transportation to the clinic when you're offering classes, or they don't have childcare. Maybe they need access to healthier food, so you can connect them with a food bank. Or some other food distribution service, that kind of thing. So just be sure that when you're screening, that you screen to intervene, that you have a resource to offer the patients. And all of those things, I've talked about it already, that can impact folks' ability to come to your health center or your location where you're offering services. And you have to look sometimes a little bit outside the box. So individual barriers that patients may have about DSMES is they may, like providers, have no idea what the heck it is, what it means. I have heard people say, don't call it education classes, because then people get in their mind that they're sitting in a classroom and it's like going back to school, and that's not what it's like. So you have to find the terminology that works for your patients. Some folks like diabetes support groups. Some people, that's too touchy-feely and they don't want any part of it. So you have to kind of know your audience and tweak your material sometimes to meet their needs and their expectations. Transportation and childcare, I've talked about a little bit already. Health literacy is another thing. With the health centers that I worked with on a diabetes quality improvement project last year, health literacy was the #1 barrier that they identified, that people don't know enough about what diabetes is. They don't understand what some of the potential complications are. Some folks are very fatalistic when they're told they have diabetes, and they're like, oh, well, I'm going to get an amputation, or I'm going to lose my vision, or whatever. And I don't think they realize how much control they can have over managing their disease. Family support is really important. I always encouraged folks to bring family members with them to DSMES services, because everybody needs to learn. It's really hard for folks to make lifestyle behavior changes if nobody in their house is doing it. So if they're trying to eat grilled chicken and everybody else has KFC or Popeyes or whatever, it's just really hard. And it's a barrier, just another barrier that we don't want folks to have to face. So encouraging family support, friend support, community support, whatever they need. Some programmatic or systemic barriers can include things like we've talked about already, inconvenient schedules. You will never find the perfect time, place, and location for everybody. You just won't. You have to do the best you can, or maybe offer it in multiple times, multiple locations, whatever's within the resources of your organization. Lack of provider engagement. I think I've talked about that a lot, about educating providers and getting them hooked in. Insurance and cost concerns. So Medicare covers DSMES. Many state Medicaids cover it, and lots of private insurances cover it as well. If your patient is uninsured, then you would need to look probably at, if you don't have a sliding fee scale option, is that something that you could implement for this program, or can you afford to offer DSMES for free? That sometimes is a little more palatable if you have insured patients that you're able to bill for, so that at least your program is breaking even. So lots of things to consider there. And then limited access. There are a lot of people with diabetes, and there's not a lot of access to diabetes self-management education and support. So if you're not currently offering it, is that something that your organization might consider, or partnering with somebody in your community who does offer it? If you don't know where DSMES services are being held, there are location maps on ADA and ADCES's website, so that you can find a DSMES service near you if you all are not actually providing it. We talked a little bit about leveraging technology already. We talked about EHRs. It's not always an easy button. Utilizing text messaging can be a great way to remind folks to that you have a class coming up, that that they've been enrolled in a class, whatever. And so I know lots of EHRs have that texting capacity, so that's an easy way to reach out to patients. So press as many easy buttons as you can. All right, let's go to the next one. Okay, so this is where I would love to hear some from you all about what barriers are keeping referrals from flowing strongly, which organizations could be engaged more effectively, which of the tools or outreach strategies that we've talked about might help, or if you have any questions for me.
Hi, this is Paola from Unity
Hi.
Healthcare. Thank you so much. I appreciate your content. That was very helpful.
Thank you.
I think I want to speak a little bit about the last one. We are transitioning to Epic as our EHR, so I'm hoping that there may be some EHR integration with
Yeah.
either the automatic referrals that you mentioned, with
Mhm.
maybe perhaps with an A1C trigger, or the opposite, not the opposite, but the other option you mentioned with an opt-out.
Mhm.
So any ideas as to what, I guess, which one I should propose to
One,
the
I will
team?
say my thoughts and prayers are with you as you transition to a new
Thank you. We need
EHR,
it.
because it is so hard. It's so hard. And it'll take a year before things settle down.
Right.
I don't care
That'll-
what they tell you. So I understand where you're coming from. So I think it depends on which version of Epic you have, but it would be a great idea to talk to the Epic reps to find out what capacity the EHR has. Most of them can run a diabetes registry. You should be able to see which of your patients have an A1C greater than 9%. And you could do outreach based off of that list.
Oh,
You can
okay.
just reach out to those patients yourself, and then see if there are automatic flags that the EHR has. So like you said, if the patient's lab work comes in and their A1C is greater than 9, that they can get an automatic flag either for a provider conversation, for a CHW to reach out, or a referral to DSMES. But
Perfect.
everyone is different, and bells and whistles cost money. So depending on which plan you have, may limit the access you have to the bells and whistles. But there should be plenty of basic things built in that could really help.
Perfect. Thank you so much for
Yeah,
speaking
of
on
course.
that. We're excited but very nervous.
Yes, it is. It is exciting and hard all at the same time. I think once it's up and running, it's smooth, and because Epic is so big, they've worked out a lot of the glitches. But there's always something that will happen.
Thank you. And then I wanted
Yes,
to
ma'am.
ask separately about, so we're in the process of trying to get accredited, and we received some feedback which was around the tracking of the goals, which I heard you speak on very briefly, but I wanted to know if you could expand a little bit. I know we help our participants create SMART goals.
Yep.
As far as tracking, can you talk a little bit about what you've done to help make it easy to track those goals to meet those
Yeah.
accreditation requirements?
Yes, of course.
Thank you.
So, and I was doing this back in the days of the dinosaurs. So we started our DSMES umbrella program in 2007. So, and lots of things have not changed since then. So I'll say this: the first thing is you're always working with your patients to meet them where they are. Let them set what they want to work on. I love that you're teaching them how to do SMART goals so that everything is kind of realistic and time framed and measurable. And then at each contact that you have with the patient, you can follow up with them about how they're doing on their goals. Sometimes they want to abandon those goals and move on to something else, and that's okay. So you can set up whatever kind of tracking system makes sense to you, whatever's easy to use. We didn't, we worked in, when I did this in North Carolina, we were working with local health departments. They were the ones who were delivering the care, and we at the state level were kind of doing the administrative functions. So they didn't have to. So some of them used like Excel spreadsheets so they could keep track of the patients who were in each class, what the patient's goals were, and then they would follow up with the patient, at each class and report on it that way. So it doesn't have to be anything super complicated. I'm trying to think, are you doing ADA or ADCES?
ADCS.
Okay. Is there not EHR, but is there a reporting mechanism that they, like ADA uses Chronicle? Do you have to use that with ADC?
No,
Yes.
ADCS just says use your own EHR.
Yeah, use
But
your own
it wasn't
EHR.
very clear from their guidance. So I wanted to, from someone who has had so much experience, I
Yeah,
wanted to ask you directly. And
yeah.
I've seen a few different ways that people do it.
Yeah, and there's no one right way. I
Okay.
think I would say do whatever is whatever makes the most sense to you all. Don't overcomplicate it.
Okay.
If this is something that as you're moving into Epic that it can help
hmm
y'all track, fantastic.
I think it
I'm
will.
all for that. If not, I mean, I'm telling you, I have seen people use a legal pad with tick marks on it for their patients. It's like whatever. I wouldn't recommend that necessarily, but a spreadsheet can
Yes.
be enough.
Okay.
So yeah, whatever makes sense for you guys with the resources you have available to you.
Thanks.
Yeah.
And there's no particular K are
We
in
did it at each
communication with a
class.
particular
Yeah.
participant.
Yeah. And it's just a simple, how are things going with XYZ that
Excellent.
they've said that they've chosen that they want to work on.
Okay.
I will tell you that was a difficult experience for us when we really shift the focus to be more patient centered, because we would see patients come in who were, who really would have benefited from losing some weight and, some more physical activity and taking their medications as prescribed. But the thing that they wanted to work on was sleep or stress. And that's what we worked on. So it might not have been the thing that we thought would provide the most clinical change the quickest, but you have to meet the patients where they are. And then oftentimes we would see when they make progress in one goal, they're ready to take on another. So yeah, just keep that in mind.
Thank you so much, Laura.
Of course. All right, I'm going to stop, Tyler. I know we only have a couple minutes left, and I think there were a couple of things that you guys wanted to wrap up.
Yes. There was a couple things that we wanted to wrap up. Before I go, does anyone have another question before I move on? Okay. So we do have a poll for everyone to complete in the chat, right, Mariana?
Yes, we do.
Okay. It's about 3 questions. Just so we can have some feedback on how the session went today. If you could complete that, that would be great. It should take you maybe like 10 seconds.
That should be up. Let me know if you're all able to see that. Thank you, Bonnie. Thank you all for joining us today as well. Please do take a few minutes to answer the questions on the poll.
Yes. And like we said in the chat, this recording and the slides will be on Living Well, and I will also send a recap to everyone who attended and to people who didn't attend. And if you would like to have, someone that might benefit from this meeting to join our listserv, please let me know. And we have 2 minutes left, but I don't think that we have any more um, information for you today. So I will say thank you, Laura, for presenting on this topic. I really enjoyed having you here, and I will give you guys 2 minutes back of your time. And I hope everybody has a great rest of your week.
Thank
Thank you.
you. Thanks,
Thank you,
y'all.
Laura.
Have a great
Thank
week.
you. Thanks
Thanks,
for having me.
everyone.
Thank
Bye.
you.
Thank you. Have a good week.
Thanks,
Thank
Ishay.
you.
Thank you.
Thank you, Dr. Beckner.
It went good, I think.